Okay, when I came across this article, I was so excited because the information is so profound and so useful. And like many out there, I was painting with a broad brush when it came to patients who had a lumbar spine disorder with a lower extremity component or a sciatic component. And I was just kind of grouping all of that into the realm of a radiculopathy. And that is actually inaccurate. And when I came across this article and read it, I was just bowled over with the information. And I love sharing it. And I know you're going to be excited about it too. The main author is Nikolai Bogduk. He's an Australian orthopedist / researcher. And he is prolific in terms of research articles and wonderful textbooks. I've got all of his textbooks and I've gained so much knowledge and information from him. And one day when you have time to just casually read, where you're not forced into it because you're in an academic environment, I would encourage you to check out some of his articles and his textbooks. So let's get on with the lesson. Okay, there's basically 4 categories of lumbar spine moderated or generated pain, just synonyms. And of course, this is actually true in the thoracic and cervical spine. But we have nociceptive back pain, somatic referred pain, radicular pain, and radiculopathy. And we're going to go over all of those in detail. And when you understand each individual one, it will just absolutely increase your diagnostic skills and your ability to look at a patient and determine the source of their pain. And of course, that gives us an anatomical sight of greater definition so that we know exactly what we're treating. Okay, number 1, nociceptive back pain. This is the most common source of back pain, and it's basically pain that's evoked by noxious means harmful, stimulation of structures in the lumbar spine. So this could be muscles, ligaments, Z joints, annulus, SI, so on and so forth. It's typically the end of 2 things. One would be tissue overload, and the other is mechanical dysfunction. Studies have been done on the sources of pain emanating from the different soft tissue elements of the functional spinal unit since the 1930s. And there's quite a bit of them out there if it sparked your interest to look into it further. But typically, when the nociceptors are activated, you have a localized dull backache. So here's the 2 examples that we spoke about that would create nociceptive back pain. One is tissue overload. Let me get my little red pointer out. All right, so right over here by the check, you can see an iliolumbar ligament that kind of has a reddened area, and of course the yellow glow indicating pain. And then you see this gentleman over here, put a check mark right on him, lifting the wrong way. He's lifting with his back instead of with his legs. And the package is way too far out in front of him. But what he did is he overloaded the iliolumbar ligament, and you can see the damage as a result of that. So there are nociceptor beds all over the place in the ligament. I'm just going to circle this. So that's the area of injury or damage, and there's nociceptor beds all over the place in there. And so he's stimulating those, and of course those are traveling up the cord, and the cortex is going to perceive them as pain. All right, the second cause that we spoke about was mechanical dysfunction. And typically this results in what's known as a locked facet, where someone bends over and they try and get up and they feel the back is locked or stuck, and it starts a cascade of pain, spasm, limitation of movement, and that's gonna be right in there, right in that facet, and it's usually due to a meniscoid that has become displaced. And you might remember those from anatomy. Those are fibroadipose lubricating pads in the facets. They keep the facet facings, or the articular facings of the articular processes lubricated. And if they become displaced, you get a locked facet. Either way, they both lead to the picture on the right over there, which is basically back pain, localized, dull, achy back pain of nociceptive origin. You'll be paying off your school loans on these folks. These patients come in regularly, and to be honest with you, they're quite easy to treat. All right, so nociceptors. This is just a cute little demonstration of how ubiquitous the nociceptors are. Soft tissue, anywhere, you name it, you've got nociceptors, which are the terminal pain sense organs that interpret what's going on with the tissues. Some of them are chemical, thermal, mechanical, pressure. Just depends what's happened to the tissue. But if you were to take that fake nociceptor red paint and just paint all those ligaments, that's how entrenched they are with nociceptors. So anything that we'll just pick a ligament over here. We've got this interspinous ligament. Just going to kind of color that in red a little bit. Right? Anything that overloads this ligament is going to stimulate the nociceptors and create a localized back pain on the right side, which is where that is located. And that would be true for any of those ligamentous structures and any of the muscle or fascia, really any of the soft tissue structures. If there's any disruption, it will be interpreted as localized back pain that's being mediated by the localized nociceptors. All right, number 2, somatic referred pain. And this was so exciting when I learned this, because I really, unfortunately, didn't fully understand the mechanism and was confusing this with radicular pain or sciatic type pain. But somatic referred pain is actually the most common source of lower extremity pain. So when a patient comes in with a lumbar spine disorder and they have a lower extremity complaint, I was quick to just jump right into the realm of that they have sciatica, and that is just not correct. More often than not, they actually have somatic referred pain. So what is somatic referred pain by definition? It's basically nociception that's generated by the same skeletal structures that we mentioned for nociceptive back pain. The soft tissue structures, muscles, ligaments, Z joints, capsules, but it's felt in an area that's distant to the structure that's actually generating the nociception. It produces referred pain alone or in addition to back pain. It's basically pain perceived in regions innervated by nerves other than those associated with the site of the noxious stimulation, which is the standard core definition of referred pain. The source of the pain lies in the somatic tissues or the bodily tissues of the lumbar spine, and so that's why they call it somatic referred pain, to be distinguished from visceral referred pain and radicular pain. Okay, just to reiterate, so I know that we're all on the same page. Somatic referred pain is pain that's perceived in regions that's actually innervated by nerves that don't come from the actual site of the injury or the noxious stimulation. So for example, the noxious stimulation may be at the medial branch of the dorsal ramus in the area of an inflamed facet joint, and the medial branch of the dorsal ramus is what innervates the facet joint. However, the pain by the patient is being felt in the anterior thigh, and that, of course, is innervated by the femoral nerve. However, the femoral nerve is not involved. That's the unique phenomena of somatic referred pain. Somatic referred pain does not, so important folks, does not involve the stimulation of nerve roots. They are not involved. It's produced by noxious stimulation, again, noxious meaning harmful, of nerve endings within the spinal structures, within the muscles, the ligaments, the discs even. They can do it as well. Z joints, Z capsules, SI joints. The basic mechanism is convergence of nociceptive afferents on second order neurons in the cord that supply the lower extremities. So primary or first order neurons are in the brain, second order are in the cord, and tertiary or third order neurons would be in the periphery, in the nerve roots and out toward the peripheral nerves. So you have this, just picture any tissue. We just take a facet capsule that's been injured and it's red and swollen and inflamed, and it's just firing impulses into the cord. And the body shunts some of those downward into the lower extremities. Henceforth, the phenomena of somatic referred pain. All right, and here's an important caveat. Because there is no compression of nerve roots, the nerve roots are not involved, these individuals will not have any positive neurologic signs. And that's really important to understand while you're doing your neuro exam. If everything is flat, everything is normal, you need to begin to think that, maybe this isn't sciatica. Maybe the nerve roots are not involved. Aha, this is somatic referred pain. Okay, I like to use this example to clarify the concept of nociceptive pain and then somatic referred pain, because they're kissing cousins. They're related to one another. So we use the example of the dimmer switch, also known as a rheostat, and it has a potentiometer in it. All right, maybe you've played with one before, maybe not, but you can see it in red with the red arrow on it. Right there, that's a potentiometer. And basically, if you push it in, it activates it, and then if you turn it clockwise, the light will go from dull to bright. All right, so nociceptive and somatic referred pain are similar. If you have tissue injury, let's say here we have the inferior origin of the trapezius muscle, right over here. Let's say just a little bit of it has torn, maybe this area over here between these two, right here, that little area has torn. The nociceptors in that area, will start sending afferents up the cord, and you'll likely feel localized back pain, deep muscle ache. But if the whole thing tears, as is demonstrated by the picture, just the whole area's got a nice tear in it, you get so much bombardment of afferents going into the cord that it is likely going to have a referred pain component associated with it. But they both have the same neurologic origin, and that is the pain sense organs known as the nociceptors, which are the terminal endings of the nerve roots that sensory innervate all these soft tissue structures. And here's another example of it, a ligament. Of course, the ligament beds are loaded with nociceptors as well. Mild ligament sprain, localized pain. Moderate to severe ligament sprain, you're going to have the localized pain and some referred pain component associated with it. So the mild tissue injury would be the rheostat turned all the way counterclockwise where the lights are dim. And then a major tissue injury would be turning that rheostat all the way clockwise where the lights are really bright. So that's the example that I like to use for that. And here's a wonderful depiction of the different neurologic tissues that can cause pain into the lower or upper extremity. So to the left, right, to the left, that's a nice microscopic view of the pain sense organs, the nociceptors deeply embedded in the tissue. Any disruption of those is going to cause pain, and the more disruption there is, that pain is going to start to refer to a distal site away from the source of the stimulation or the injury. And then, of course, to the right, totally different mechanism. We're about to discuss that. That is a nerve root, and that is direct neurologic innervation into the lower extremity. Totally different animal. Of course, there's your anatomic paint, nociceptor red. Again, think of any soft tissue anywhere in the body and just totally cover it in that paint. And that's how ubiquitous the nociceptors are. What are the characteristics? Really important that you just tuck this in your memory and don't forget it. It's going to serve you well for the rest of your career. Somatic referred pain is dull, it's achy, it's gnawing, it's aggravating. Sometimes it feels like pressure, like an expansion in the tissue. It tends to be in fixed locations, into wide areas where the boundaries, the exact pinpoint boundaries are actually difficult for the individual to define. So they may put the hand in, on their thigh. I mean, they know where the pain is. But if you ask them for, specific boundaries, they start pointing all over and just, wrapping their hand around the leg. They have attempted to make segmental maps of various tissues, but they always come up inconsistent, and they've yet to do that. So in other words, they might check ligaments. Researchers will check let's check the intraspinous ligament. Let's noxiously stimulate it on a population of subject volunteers and see if we can come up with the pain pattern for that ligament. And they have not been able to do that consistently, so we don't really have any maps for that. One thing we do know is the patterns are typically not dermatomal, right? They don't follow the well-established dermatogenous patterns, although it can be confusing at times because they are similar. The most common distribution for somatic referred pain in the lower body, coming from the lumbar spine, would be the gluteal region and the proximal thigh. So most people will complain of pain into the buttock, upper buttock, mid buttock, sometimes down into the upper thigh, maybe the lateral thigh, anterior thigh, groin. It can go as far down as the foot. When there's a lot of stimulation, the body can shunt those impulses all the way to the foot. And that is when it might become confusing. You might think you have a sciatic case, but there's a really simple way to differentiate, and that's basically by using the straight leg razor, which stimulates nerve roots, typically does not stimulate nociceptive beds in the soft tissue structures of the lumbar spine. So dull aching lower back pain that also spreads into the lower extremities, settles into a relatively fixed position, and has no neurologic signs. That is so important. No neurologic signs should be recognized as somatic referred pain. All right, so check this out. These could be any patient, right? We've got 4 patients. Let's just take the example of the starred one right here, right there, right? So maybe that's a patient filling out your entrance form and trying to explain where their pain is. So we have, this is the posterior view right here, and then that's the anterior view right there. And if you look at that, darn, does that look like it might be sciatica? But that's up to you, the physician, to differentiate. So is it somatic referred? Is it radicular? Are the nerve roots involved? Are they not involved? So these are actually referred pain patterns that were evoked by noxiously stimulating the interspinous ligament at their listed levels, right? So we got L3, L4, L5, and S1 interspinous ligaments. And you can see it might be confusing, especially the L5. I mean, that looks like a fairly common radicular pattern that would be coming from a nerve root. So how do we distinguish between the two? Well, you just basically, when the exam time comes, you put the patient on their back and you do a straight leg razor. And of course, the straight leg razor is designed to put tension on the lower lumbar nerve roots to assess any space-occupying lesion in the path of one of those lower lumbar nerve roots. It will not stimulate the tissues, such as the interspinous ligament, and so it will not be provocative. So that test is invaluable in differentiating between lower extremity pain of radicular origin or nerve root origin and lower extremity pain coming from the nociceptors. All right, number 3, radicular pain. So radicular pain is different from somatic referred pain. When you see the prefix radic, R-A-D-I-C, what does that mean? Well, it means root. When you define something as radicular pain, what you're saying is that patient has nerve root involvement. And so if you're going to use that term, make sure that the orthopedic and neurologic tests confirm your assessment. All right, so the mechanism is different because the pathoanatomic source or the site of pain production is different. Now we're dealing with nerve roots, not nociceptive nerve endings. The clinical features are also different, and that is so important. When you become familiar with these, you'll know when you have one or the other. Physiologically, radicular pain is pain that's evoked by what's called an ectopic discharge, which is kind of a pathologic discharge or impulse that's emanating from the spinal nerve root. We're about to clarify that for you so that you fully understand that. And I'll show you actually a visual of that on the next slide. But an ectopic impulse is a pathologic action potential, or a pathologic, let's use the word abnormal instead, pathologic, an abnormal axonal impulse, because it begins in the middle of the axon and it proceeds simultaneously outward to the cell body and the periphery. It's supposed to start in the cell body. You'll understand it more in a moment. And this is absolutely vital that you understand this, folks. I'm going to actually go ahead and highlight this one. So important. So important. Disc herniation is the most common cause of radicular pain. That is so valuable, folks, because when you do assess that the nerve roots are involved, you can now, with a great degree of certainty, assume that they have a disc. So important. And inflammation of the affected nerve root is critical in initiating a pathophysiologic response from the nerve root itself. All right, so here's your example of an ectopic impulse, or a pathologic abnormal axonal impulse. So to the left you have your cell body, right? Cell body, and then you have your axon and the terminal endings of the axon. You know, this square right here could be any target tissue, anything. It could be a ligament, it could be a muscle, it could be a tendon. That's a normal axonal impulse. If something protrudes, as in a herniated disc, and hits the spinal nerve root, then you can get what's known as an ectopic axonal impulse, or an abnormal action potential. So you can see the flashing red area indicates some type of lesion that's affecting the nerve root and causing impulses to go into both directions. What causes this? It could be mechanical. Mechanical is usually the nerve is abnormally stretched. Compressive, that's usually due to some space-occupying lesion, such as a disc herniation or protrusion. Inflammatory, well, that nerve can inflame by both mechanical or compressive forces to the nerve. and then chemical. Chemical would be if some nuclear material leaked on it. But that's the mechanism, typically, of radicular pain. All right, clinical features, here we are again. Very distinct qualities of radicular pain. So that the complaints are going to be different. You know, for somatic referred pain, that's going to be your dull, achy patient. But the radicular case, ooh, that's the sharp stabbing, shooting, electric, lightning. Radicular pain typically travels along the full length of the lower limb. Wow, did you know that? A patient comes in with low back pain and is going into their buttock and the back of their mid-thigh. That should be a clue right there that it's probably not radicular. It typically travels along the full length of the lower limb, going all the way into the foot and up to the toes. It's no more than 2 to 3 inches wide. I look at it, it's like duct tape. Imagine just running a piece of duct tape down a particular dermatome. That's very descriptive of how it would feel to the patient. In vivo studies reveal that this is the only type of pain. So remember what in vivo means, right? In vivo, living subjects, volunteers. Studies on living volunteers reveal that the only type of pain produced when they stimulate nerve roots is as described above. And oddly enough, in vivo stimulation of normal nerve roots does not evoke radicular pain. When we say normal, we mean that they're not inflamed. They must be inflamed in order to create a radicular pattern. And then animal studies reveal that for compression alone to be painful, it must involve the dorsal nerve root ganglion. So there's some good information for you. Check out this study. Where they find these volunteers, I don't know. But so in one study, the affected nerves were challenged by squeezing them with forceps in patients who were awake. And here's this one is crazy. In another study, sutures were placed around the nerves while they were in surgery, and then the suture itself, right, the thread, the string, was let out through the wound and kept out there so they could be pulled on the following day. Right? I don't know that I would volunteer for that one. The pain evoked when they did that was very distinctive. It wasn't dull, it wasn't achy, it wasn't pressure, it did not have the somatic referred pain pattern. It was lancinating, which means stabbing, sharp, and it traveled along the whole length of the lower limb in a band-like pattern, like duct tape, 2 to 3 inches wide. And this was the only type of pain that they were able to produce by stimulating the nerve roots, by either squeezing them with forceps or tugging on them through the sutures. So reciprocally speaking, it is the only type of pain that should be interpreted as radicular pain. So in your interview, whatever you call it, history consultation, you would be asking the patient to qualify the pain. In other words, Mrs. Jones, is your pain dull and achy or sharp and stabbing? That's all you need right there, because they will tell you, oh, it's just dull and achy, doc. Oh man, doc, it is sharp and stabbing. When it hits, whoom, it's killer. that will tell you the neurologic source of the pain. And again, if it's radicular, if it's coming from a nerve root, you probably have a disc case in the office. So here's both examples. To the right, that's the lancinating, sharp, shooting, stabbing quality of radicular pain going down the whole lower extremity, emanating from the lower back. And there's your diffuse, dull, achy, somatic referred pain. Stellar, folks. This information is absolutely stellar. Ah, we've got one more. See, I bet some of you thought radiculopathy just covered everything going into the lower extremities. Or maybe you didn't. But it's its own distinctive entity. So in order to have a radiculopathy, a conduction block must exist along the spinal nerve root. What is a conduction block? Well, it's a neurocompressive lesion intense enough to impair intraneural blood flow, to cause edema, intraneural edema, to reduce the flow of axoplasm, and diminish the impulses, right? The axonal impulses going through that nerve root. Studies have been done. It takes about 20 millimeters mercury of pressure to produce a conduction block in a nerve root. They're much more sensitive than peripheral nerves. Peripheral nerves take about 100 millimeters of mercury to produce a conduction block. All right, so we know that nerve roots have a sensory and a motor component. When sensory fibers are blocked, compression block, you get numbness, maybe some tingling, and that numbness is typically dermatomal in its distribution. When the motor fibers are blocked, then of course you're going to get muscular dysfunction or weakness. So here, this is important. Radiculopathy is not defined by pain, although these patients likely have a lot of pain. But that's not what defines it. What defines radiculopathy is having positive neurologic signs. And of course, numbness and weakness are definitely neurologic signs. Radiculopathy and radicular pain commonly occur together, right? So a patient with, sciatic pain, that's killing me, doc, and neurologic signs such as numbness and weakness, maybe a diminished reflex, they can occur together. However, radiculopathy can occur in the absence of pain. They may only have numbness and weakness. Radicular pain can occur in the absence of radiculopathy. So let's try and explain this. Let's say we have a patient with a right posterolateral disc herniation at L5, affecting the S1 nerve root. We do a straight leg razor on them, and it's positive for reproduction of that leg pain at 15 degrees. All right, so all we know right now is the nerve roots are involved. That's all we know. And so we can qualify that case as having a radicular component. All right, now let's go in and do a neurologic exam. Let's test the reflexes and let's test the muscles. And it was S1, L5 disc S1, so we would check the Achilles reflex and the plantar flexors. And let's say they were both normal. And then maybe you did a little pinwheel evaluation of the dermatomes, and that was normal. There was no change in sensory input from one extremity to the other. So what that tells us is that all we have is radicular pain. Let's reverse that. Let's say we do that straight leg raiser, and again it's positive at 15 degrees. And now we go in and check the Achilles reflex, and it's diminished. We muscle test the plantar flexors, and they're slightly weakened. And we do a dermatome assessment using the pinwheels, and the patient says they're having less sensation around the side of the foot and the small toe area. So now we have positive neurologic signs. We now have a true radiculopathy. So the defining difference between radicular pain and radiculopathy is radicular pain does not have positive neurologic signs associated with it. Radiculopathy does. So back pain and somatic referred pain are really common, folks, really common. Again, you're going to be paying off your loans on these folks, and gladly they will appreciate you, and you'll build successful practice on cases like this. Radicular pain is not common. When strictly defined, it's about 12%, right? I round those off. It says 12 and 88. I do 10 and 90. So about 90% of your patients who present with a lumbar spine disorder with lower extremity involvement, 90%, that's 9 out of 10, not radicular, which means not disc. And disc cases are not that common. Imaging can be justified for radicular pain or radiculopathy because the causative lesion is, as we've discussed, a disc. So you might want some imaging. Not particularly justified for nociceptive back pain or somatic referred pain because these are usually just common garden variety back cases that will respond after a short series of chiropractic adjustments. So here's a really cool chart. Certainly not going to go over every last aspect of it, but it goes over all four. Right? Your nociceptive back pain, your somatic referred pain, your radicular pain, and then radiculopathy. And then, does it have neurologic signs? Is the nerve root involved? Nerve root tension signs, we'll discuss those later. Those straight leg raiser is the mother of all of those. Nociceptors stimulated, dermatomal pattern, is the disc involved, pain above the knee, pain below the knee, right? So anyway, you can use that chart for your benefit to try and help you with your diagnostic skills. All right, so diagnostic difficulties arise when patients present with combinations, and they will. They will. And we cannot always zero in, but we do our best. So here, patient presents with back pain of nociceptive origin, right? Maybe they strained a muscle. But the patient also has referred pain into their groin and into the back of the thigh, and that's somatic referred. However, he also has a leaky disc, which is causing chemical irritation of the nerve root, leading to radicular pain. Radicular pain typically has an inflammatory component associated with it, and if it stays that way long enough, you're going to get a conduction block, and that it's going to turn into a radiculopathy because the nerve root is now swollen. Wow. So don't let it confuse you. You can actually have all four at the same time. So each feature then has a separate cause, a separate mechanism, invites separate investigation and treatment protocols, which unfortunately at times can be difficult to distinguish in clinical practice. So we always in the Cox technique go from lesser to greater. And whenever you have a case where you have multiple components of involvement, always start with protocol 1. And then as they progress along and reach that 50% mark, then you can always go into protocol 2. And then of course, once you're at protocol 2, you can then begin to introduce other chiropractic methodologies for the correction of vertebral subluxation and betterment of the patient. All right, so patients can have back pain, patients can have sciatica. The two symptoms have separate mechanisms and causes. Features, causes, and mechanisms of one entity cannot be attributed to the other. Disc herniation, can't reiterate this enough. Disc herniation, get my trusty highlighter out. Disc herniation is the most common cause of radicular pain. Disc herniation is not a common cause of back pain, right? 1 out of 10. The vast majority of patients with nociceptive back pain do not have radicular pain, which means they do not have a disc herniation. Somatic referred pain is far more common than radicular pain. Radicular pain should be regarded as the exception. Somatic referred pain is often mistaken for radicular pain. Remember, if you're going to say, I have a patient with sciatica, well, of course, sciatica is kind of a common term for radicular involvement of the lower lumbar nerve roots. If you're going to say you have a patient with sciatica, they better have nerve root involvement. And objectively and subjectively, you need to show that in your assessment. Less iatrogenesis. Whoa, that's a big word. Less iatrogenesis. What's iatrogenesis? Well, that's the doctor screwing up. Less iatrogenesis will occur as we become astute in discerning between the two. Wow. Awesome information, folks. Hope you enjoyed that. That will give you a cutting edge on your diagnostic skills and make you a more astute diagnostician and a better chiropractor. Voila. Ouch.